Okay, welcome everyone. We will go ahead and get started. Thank you all for joining today for our 9th webinar in the Tiny Webinar series, focusing on obstetric interventions for deliveries at less than or equal to 23 weeks. I am Dr. Leanne Pavlik, a neonatologist at Nationwide Children's Hospital in the US, and we are pleased to welcome 2 speakers today. First up is Dr. Kelly Gibson, who is the Division Director for Maternal-Fetal Medicine and the Associate Director of Obstetric Informatics at the Metro Health System, and an associate professor at Case Western Reserve University in Cleveland, Ohio in the US. Dr. Gibson is a member of the Society for Maternal-Fetal Medicine Board of Directors, a principal investigator for the NICHD Eunice Kennedy Shriver Maternal-Fetal Medicine Research Network for the Case site, and a clinical advisor for the Ohio Alliance for Innovation in Maternal Health Projects. Our other speaker is Dr. Ashley Battarbee, who is an associate professor in the Division of Maternal-Fetal Medicine at the University of Alabama at Birmingham in the US. Dr. Battarbee is actively involved in clinical care, resident and fellow education, and research with multiple NIH-funded clinical trials. She holds multiple leadership roles, including a member of the Society for Maternal-Fetal Medicine Publications Committee, and is on the Tiny Baby Collaborative Steering Committee. Joining me in moderating today are Dr. Cheryl Battarbee, a returning moderator, who is a neonatologist at Chelsea and Westminster Hospital and Imperial College of London, and Dr. Colm Travers, a neonatologist at the University of Alabama at Birmingham in the US. A few housekeeping notes for today. Our webinar is recorded and will be posted shortly to our website at tinybabycollaborative.org. We have multidisciplinary attendance, including some families and children and former NICU patients. And then finally, please feel free to use the Q&A feature in Zoom to submit questions, and we will also cover some questions that were submitted during the sign-up process during our moderated discussion in the second half of today's session. We are also pleased to announce that the Tiny Baby Collaborative will be hosting another workshop at the 2025 PAS meeting in Honolulu, Hawaii. We are planning an interactive scientific program with international experts and small group workshops. And we have a 3-hour session on the Friday of the conference, Friday, April 25th, from 7 to 10 a.m. Shown here at the bottom in the highlight, when you register for the conference, you can sign up for this session. We do have limited space, so please only RSVP if you plan to attend. For today's webinar, we had 50% neonatologists sign up to attend, and we have a nice breakdown of other NICU providers, including nurses, nurse practitioners and physician assistants, and NICU trainees. We are also happy to have 7% of our signups come from OB or MFM colleagues, 5% from other healthcare providers, and 5% from a category of other, which includes researchers and former NICU parents and families. To review the responses from the questions that were asked during registration, first we asked the earliest timing at which steroids will be given antenatally for threatened preterm birth. And you can see here that more than 60% of registrants report that at their site, steroids will be given at 22 and 0 or earlier. And about 30% report that steroids will be given between 22 and 5 and 23 and 0. Responses were more divided for the earliest gestation at which a C-section will be offered, with about 1/3 responding as early as 22 and 0, 40% responding 23 and 0, and about 20% saying that they will not offer a C-section until 24 and 0. About 60% reported that magnesium sulfate for neuroprotection will be given for threatened preterm birth as early as 22 weeks. And again, about 1/3 state that magnesium will be given at 23, but not 22 weeks. A small number also reported only giving magnesium at later gestations or not given at all. And then finally, about 1/4 of our sites stated that delivery on call is prioritized for preterm delivery at less than 24 weeks. So with that said, I will turn it over to Dr. Gibson for our first talk. Thank you again, everyone.
All right, can you see my screen?
Yes.
Great. All right, well, thank you very much for inviting me to speak today. I'm going to talk a little bit about some of the interventions from an obstetrician's perspective that we can do at these paraviable gestations. For what I'm going to cover first, what is a periviable birth? Where should these births ideally happen? And then when should we think about antenatal corticosteroids? In terms of definitions, the gray zone of periviability is something that has changed, certainly through my career, I'm sure through many of yours. And it's defined as the gestational age between which neonatal intensive care is futile, meaning we don't have a chance, and when it's highly effective. It has changed over time due to an improved understanding of both developmental physiology as well as improved tools to treat these tiny babies. Generally, this falls between around 21 and 24 weeks of gestation. It's also important to consider the standard error in the estimation of gestational age. Outside of someone who had an IVF pregnancy, we don't know exactly when that egg and sperm met up, and so there may be a few days difference in the actual gestational age versus what we call our best obstetric estimate, which could explain some of the variation. You know, if we think a baby is 23 and 0, they may actually be a few days earlier or a few days later, which could affect their chances of survival. Looking at this kind of in a graphic form, we are talking about this gestational age right down here, which this is taken from an article in 2004. And at that time, 22 weeks and below was considered in the category of fetal loss. And now 20 years later, we're talking about interventions at this time. So it really demonstrates how quickly some of the things in this field have moved. It's also important to think about denominators. When we look at studies on periviable birth outcomes, it's really important to say which babies are considered in that denominator group for percentage of survival and which are not. In this example, which is looking at some Swedish data, if you just said, say at 23 weeks, your chance of survival is 50%, well, 50%, just over 50% of babies were actually stillborn. And so if you don't account for that stillbirth in your denominator, it can make your percentage of survival actually look much less. Looking again at some Swedish data, this is data looking at 2004 to 2007, and then essentially a decade later. And this is the percentage of stillbirths at 22, 23, and 24 weeks. You can see that these percentages of stillbirths changed over time in the 22 and 23 week periods. And part of this is probably due to more active obstetric intervention. When I was first in residency and we didn't necessarily intervene at 22 weeks, if someone was laboring and we couldn't stop it, we typically would not monitor them. And so many of those pregnancies that came in with a living fetus ended up as a stillbirth and would have been in this category here. As we've started intervening, more actively monitoring, we can lower that risk of stillbirth and therefore have a live neonate to potentially resuscitate. It's also, hopefully you can see this, also important to think about what are the reasons for a periviable birth at these early gestations. And this graph, I think, very clearly demonstrates the reasons change over time. When we look at the 22, 23, 24 weeks, we see a much higher percentage of the etiology for preterm birth being related to premature rupture of membranes or labor or an infectious process. When we look later in the preterm area, we see more gestational hypertensive disease, maybe maternal indications for a delivery. And as you would guess, a baby that's coming out of an infected intrauterine environment may respond differently to resuscitative efforts than one that was iatrogenically delivered early due to a maternal condition. Looking at that data a little bit differently, babies who are born at 22 to 23 weeks have about a 2.5 times increased chance of having chorioamnionitis at the time they were delivered than those at 28 weeks. So that kind of defines periviable birth. Well, we're here today because there's different dilemmas in this gestational age. As neonatologists, you have a baby, hopefully live, born, handed to you, and you need to decide, do we initiate intensive care for this baby? As an obstetrician, we have a few more questions. Do we give steroids? Do we monitor? Do we intervene with a major abdominal surgery that has implications for future pregnancies? If we're going to intervene, why are we intervening? Is it for fetal distress? Is it for malpresentation? Is it for anyone who's just this early? And then what are the effects on the mother and, again, future pregnancies? We also want to think about the parents in this situation. These are parents who are coming in really almost at the middle of their pregnancy. They're frightened, they are often vulnerable, they're often in pain, and they're usually poorly equipped to comprehend this fairly complex information that we're going to be bringing to them. We also have to think about the slide I just showed in terms of chorioamnionitis. Often these patients are sick, and we're trying to counsel them in the midst of all of this. It's also a challenge that survival data is very variable between centers. Some centers may present a 60 to 70% survival at 22 weeks, while other centers it may be closer to 0. Also thinking about that denominator factor. When they're reporting their data, who's included in that denominator to think about survival? And then we have to think about the fact we have different perspectives as obstetricians from neonatologists. We've trained a little bit differently, and sometimes this leads to fragmented or uncoordinated communication. Webinars like this are to try and bring that communication together so that we're all on the same page. But even here in the US, some of the guidelines that our National Institute has, ACOG, may differ from the American Academy of Pediatrics. Looking at that discordance between obstetricians and neonatologists, we see that from this paper published a few years ago, the discordance in our counseling and in kind of what I'm doing as an obstetrician, am I intervening and giving steroids versus when a neonatologist may resuscitate, seems to center right in this window we're talking about, the end of the 22nd week into the 23rd week. Once you get later on, we seem to be much more concordant in our counseling, but earlier on, we have some varied opinions. So next, where should periviable births happen? Well, we know there's many factors that influence survival, whether it be fetal sex, their race, which may have to do with other structural factors, birth weight, what interventions are given, like steroids or surfactant, but also here, whether or not this neonate is inborn definitely impacts their odds of survival. Looking at this from a different study, these are, again, looking at the Swedish data, and the babies that were inborn in both of these epochs both had a much higher chance of survival than those that were outborn. Here in the US, this is an example of a maternal transport briefing form in order to take a laboring patient from maybe a level 1 or level 2 maternal center to a level that has the ability to care for a very early gestational age fetus. So the bottom line is getting the mother to a hospital specializing in periviable birth increases the likelihood of a live birth, eliminates the risk of a postnatal transfer, and leads to improved outcomes. Well, what about antenatal steroids? Well, first, why do we give steroids? When we look at the fetal development in this range that we're talking about the canonicular phase of lung development. And that phase actually goes from 16 to 26 weeks. In this phase of lung development, the respiratory bronchioles are developing, the saccules are developing, you're getting thinning of that capillary epithelial space for gas transfusion, and you're also having development of the type 1 and type 2 epithelial cells, which are the cells that receive the greatest impact of the steroids. As those lungs are developing, there's an impact on the lung tissue for steroids, but there's also an impact on many other organ systems in the fetus when we give steroids. So this demonstrates that there is an impact on the fetal brain, the skin, the liver, intestines, and pancreas. Looking at several different studies, steroids have been associated with a lower risk of RDS, so that's the lungs, a lower risk of overall perinatal death and neonatal death, a lower risk of intraventricular hemorrhage, and a lower risk of NEC. Babies who were exposed to steroids tend to need less respiratory support, have better APGAR scores, and less developmental delay later in childhood. Now, these results were all in fetuses that were 22 to 37 weeks. We have extrapolated much of this data down to 22 weeks, and I'll go through that in my last few slides. Also important to note that outside of affecting blood sugars for a pregnant patient with diabetes, there are no known significant side effects for giving steroids for mothers. Well, as I said in the last slide, those data were for 22 or 24 to 37 weeks. What about less than 24 weeks? Well, this is by one paper showing the impact of steroids at 22, 23, 24, and 25 weeks. Infants that had been exposed to steroids overall had much higher chances of survival than those that had not been exposed. And this was true at each week of gestation. If we look at number needed to treat, which is often an easier way to interpret some of these statistics, the number needed to treat in terms of fetuses to prevent a death is exponentially lower at earlier gestational ages than at later gestational ages. And I would extrapolate that at 22 weeks, we're also probably here in the less than 10 needed to treat in order to potentially prevent a death. Looking at multiple studies that have examined the question of whether steroids hold benefit in the 22 to 23 week period. We have studies here from the US, from Europe, from Japan, and overwhelmingly, they all show an effect size that steroids hold benefit. Overall, there's more than 60,000 neonates represented in this data. They're all observational, but there's unlikely to be an RCT at this point of whether to give or withhold steroids in this gestational age. And so this data is likely to be the best data that we will have. And it seems overwhelmingly to support that steroids do have benefit at this gestational age. In 2021, ACOG, our obstetric national guidance, actually came out with a change and said that antenatal corticosteroids may be considered at 22 and 0 weeks to 22 and 6 weeks of gestation if neonatal resuscitation is planned and after appropriate counseling. This was a change from prior recommendations that had said only to 23 weeks and really demonstrates the fact that this gray zone of periviability has moved into the 22nd week. So as some take-home points, births at 22 to 24 weeks are not the same as births at older gestations. There tends to be more PPROM, more infection, and less hypertensive disease. There are also much higher rates of stillbirth. Delivering at a perinatal center with expertise in periviable services saves lives and decreases morbidity, thus arguing for networks and regional care to get these deliveries to happen at a center where there's the correct resources. And third, antenatal steroids are about far more than RDS and do appear to hold benefit at as early as 22 weeks. So thank you very much. I'm going to hand it over now to Dr. Battarbee.
All right. So I have the privilege of talking about kind of all of the other stuff that we think about before a periviable birth. So in the next 15 or 20 minutes, we're going to go through some of the other OB interventions that might be considered for threatened periviable births, including things like magnesium sulfate, antibiotics, how to choose the best mode of delivery, as well as delayed cord clamping. I know there are other things that are not included here, things like on-call deliveries that I know we surveyed about, and we look forward to discussing those hopefully in the Q&A if there's time. There just is not enough time to go through all of these things in just 15 to 20 minutes. So starting off with magnesium sulfate, when given to a pregnant woman, has been shown to reduce the risk of moderate or severe cerebral palsy in her child if given before preterm birth at 24 to 31 weeks in the BEAM trial, and that was done in the early 2000s. It's still somewhat unclear the exact mechanism of action that resulted in this impact on cerebral palsy, but some of the theorized mechanisms, including stabilizing blood pressure and normalizing cerebral blood flow, prevention of excitatory injury by stabilizing neurons and blocking excitatory neurotransmitters, some protection against oxidative injury via antioxidant effects, as well as protection against inflammatory injury. And so while there's limited data in the periviable period, I'm going to go through two studies next that provide some background for whether or not we should use it at earlier gestational ages. So the first is a retrospective cohort study of 4,355 neonates. The entire study looked at neonates born at 22 to 27 weeks. And we're going to focus on the cohort or the strata of just those born at 22 to 25 weeks. And so they looked at the effect of magnesium exposure on multiple adverse neonatal outcomes and found that giving IV magnesium sulfate to the pregnant woman was associated with a lower risk of mortality by about 25%, a lower risk of stage 3 or more IVH or periventricular leukomalacia, about a 20% reduction, with no differences in NEC, ROP, or BPD. There was a slightly higher risk of infection by, again, about 25%. That was somewhat interesting and not entirely clear why that was the case, but it was just an observational study, and so could be just due to chance or some other measure of unmeasured confounding that had not been accounted for. But overall showed potential benefit of magnesium sulfate even in that earlier gestational age window from 22 to 25 weeks. The second study was a prospective cohort study of about 3,000 neonates from the Neonatal Research Network that were born at 22 to 26 weeks of gestation. And this study itself was focused on evaluating the effect of both corticosteroids and magnesium when given together. But if you dive into some of their data and really tease out all of those neonates who received magnesium, whether it was magnesium with steroids or magnesium without steroids, and compare those rates of adverse outcomes to those who didn't receive magnesium, again, could have gotten steroids or could have gotten neither magnesium nor steroids, you see that at 22 to 26 weeks, administering magnesium sulfate was associated with a lower rate of severe neurodevelopmental impairment or death. 36 or 37% versus 45%. So again, supporting that even at these early gestational ages, magnesium sulfate may also provide a benefit. And as we go along, I'm going to kind of show the most recent data that, I was able to find, and then compare that against what we currently have from the ACOG and SMFM guidelines. And I will point out that these guidelines were published in 2017, so almost 8 years ago. And so they may vary between, what the more recent literature says. And I think something that we can talk about is whether or not some of these guidelines may need to be updated. So the kind of existing ACOG and SMFM guidelines do not recommend giving magnesium at 20 to 21 weeks or at 22 weeks. But I think some of the data that I just showed, as well as some upcoming studies that should be out in the next year or so, may start to show, just like we saw for steroids, potential for benefit at 22 weeks. They recommend considering magnesium sulfate at 23 weeks and then recommend giving magnesium at 24 weeks and beyond. So moving on to the next intervention, antibiotics. I think we first have to consider why antibiotics are being given. So there are multiple different indications, and that's how I'll break down the discussion. So first, in terms of periviable preterm pre-labor rupture of membranes, or periviable PPROM, is there evidence of benefit to giving antibiotics in that scenario? Well, we know from the Mercer study that was done in the 1990s that broad-spectrum antibiotics given after PPROM at slightly later gestational ages, 24 to 32 weeks, has been shown to prolong pregnancy and reduce neonatal morbidity. So beneficial a little bit later on, but what about these earlier gestational ages? Well, what do we know about them? We already heard from Dr. Gibson that there's a high risk of infection, chorioamnionitis, and particularly among those who have periviable PPROM, that risk can be rather high. Different observational studies have quoted risks of up to almost 60% among individuals with periviable PPROM that choose expectant management. While there's limited, however, the data in the periviable period is really limited with regards to the type and the timing of antibiotic administration because different institutions may practice differently. And so there's not a consistent antibiotic that's given, which makes some of the data harder to combine. However, pregnancies with longer latency and those with higher rates of neonatal survival were more likely to have received antibiotics in two studies that were done in 2020 and 2022, suggesting that maybe there is a benefit to latency antibiotics even at these early gestational ages. And so what does ACOG and SMFM say? Again, from 2017, they recommended considering antibiotics as early as 20 weeks, knowing again that infection is going to be more prevalent at those earlier gestational ages, and then recommend giving for latency at 24 to 25 weeks. In the newest SMFM guideline on management of previable and periviable PPROM, they also added a comment about what to do with previable PPROM at less than 20 weeks. And while there wasn't a clear benefit to giving antibiotics at less than 20 weeks because of a lack of evidence, they do acknowledge that shared decision-making could be used in determining if antibiotics were to be given at the time of PPROM at, let's say, 18 or 19 weeks. So some other indications for antibiotics, preterm labor with intact membranes. Cochrane review of 14 studies showed no difference in perinatal mortality and actually a higher rate of neonatal death when antibiotics were given. This was, again, at later gestational ages, and there is limited data specific to the periviable period, but in general, it's not recommended in the US. And then finally, intrapartum group B strep prophylaxis. We know that GBS is a leading cause of neonatal infection, and the primary risk factor for early onset GBS sepsis is maternal GI and GU colonization. Because vertical transmission usually occurs during labor or after ruptured membranes, intrapartum antibiotics have been used and shown to reduce colonization and reduce vertical transmission. Again, limited data that specifically looked at GBS prophylaxis in the periviable period, but suggestion that it may have a similar mechanism at later gestational ages. And so what does ACOG and SMFM say? In this guideline, they actually did not recommend giving it at 20 to 21 or even 22 weeks. Again, I think as we saw with their updated guideline for steroids, I think particularly this recommendation at 22 weeks may require some reevaluation, particularly as we're seeing higher rates of resuscitation and survival at that gestational age. They recommend considering to give it at 23 weeks and then recommend giving it at 24 to 25 weeks. So third is the mode of delivery, and we'll spend kind of the most time talking about this because I think there is a fair amount of controversy and some limitations of the existing data. But this is trying to decide, is it better to do a vaginal delivery versus a cesarean? So some of the limitations in the existing data include, number one, whether you plan to have a vaginal delivery or you actually are successful to have a vaginal delivery are different things. I think, there is no failed cesarean delivery, but there are definitely times when you would love to have a vaginal delivery, but it's not the ultimate outcome. And collecting that in the data is somewhat limited. The second is the willingness to perform a C-section. So in looking at some of these studies, you may not know if the vaginal delivery was a result of someone who felt like labor was going well, the fetus was tolerating it well, and had a successful vaginal delivery, versus those who maybe were monitored by someone who was unwilling to perform a C-section, and that could affect the outcomes in that group. And then finally, and Dr. Gibson alluded to this as well, there are different types of indications for a cesarean. So you may do a cesarean solely because of a breech or a transverse presentation. You may be doing a cesarean because of abnormalities that you've observed in the fetal heart rate tracing or a cord prolapse, which would obviously impact outcomes. And then finally, in addition to thinking about the neonatal benefit to cesarean delivery compared to vaginal, we also have to consider maternal morbidity, as it is a major abdominal surgery. And so that includes both risks of the actual C-section itself, but also has implications for future pregnancies. So with uterine surgery, cesarean delivery included, it increases the risk of abnormal placentation and placenta accreta spectrum in future deliveries. At this gestational age, most cesarean deliveries are going to be classical hysterotomies, meaning a vertical incision on the uterus. And I'll show you a picture in a few minutes and talk a little bit more about what that means. And then finally, with these more complicated classical cesarean deliveries, there is an increased risk of uterine rupture in future pregnancies and catastrophic injury to those fetuses. So what does the data say? So first, I'm going to start with a study that was done in 2012, or it was published in 2012. It included 4,352 singleton deliveries at 24 weeks to 31 and 6 weeks, so a little bit later. And this is data from the Consortium on Safe Labor, which included many hospitals across the United States. And what they wanted to look at, and we kind of touched on this briefly as a limitation of some studies, is the attempted route of delivery. So whether you tried to have a vaginal delivery versus a planned scheduled cesarean delivery. And what they found was that the association between the attempted route of delivery and neonatal mortality was different depending on whether the fetus was in a vertex or a breech presentation. So what was that difference? Well, for vertex neonates that were born between 24 and 27 weeks, there was no difference if you planned to have a vaginal delivery versus you planned to do a C-section. So no difference in mortality. However, for breech neonates at 24 to 27 weeks, there was actually a higher rate of neonatal death with attempted vaginal delivery versus a planned cesarean. So limitations of this study include that only about a third reported antenatal corticosteroid use because it was done at in the early 2000s. And so while they were able to look at adjusting for that potential confounder in a subgroup, that was only able to be done on a third of the deliveries. And then finally, there is potential for confounding by indication, which really spans all of these studies because they are just observational studies. And that confounding, what that means is, was there something inherently different about those neonates who they planned to do a C-section on versus those who they planned to have a vaginal delivery? So perhaps the babies who had a planned vaginal delivery, more of those may have been neonates who either the patients did not desire resuscitation, or there was something else that made the providers, less likely to resuscitate or be as aggressive, and thus were not willing to accept the maternal risks of a C-section, and thus may make outcomes look slightly different in the vaginal delivery group. So the second study is a retrospective cohort study. This was about almost 2,000 neonatal deliveries, really focusing on the breech deliveries. And this was among slightly earlier gestational ages at 23 to 24 weeks. This study used birth and death certificate data and discharge data from 3 states across the US. And what they found, similar to the previous study, was that survival was better among, again, these were breech presenting neonates who were delivered via cesarean compared to vaginal. And that held true at both 23 and 24 weeks. In some additional sensitivity analyses, they looked at differences in morbidity and mortality to see if that depended on the reason they were doing the C-section. So we said, not all C-sections are done for the same reason. And they found that there were differences if there were C-sections done for emergent versus non-emergent. And so what they concluded, again, was potential for confounding by indication, where physician judgments about survivability or parental preferences for intensive care may have a greater influence on outcomes. Getting to our third study, this was a much larger study, again, done at slightly earlier gestational age. There's kind of a reason why I ordered them these ways. So this was a retrospective cohort study of over 11,000 neonates delivered at 22 to 23 weeks who received postnatal resuscitation. This is done a few years later, 2007 to 2013, and the data was derived from vital statistics data. And similar to the previous studies, they showed higher rate of survival to 1 year with cesarean delivery versus vaginal delivery, and found that to be true both at 22 weeks as well as 23 weeks. And when they also looked at potential other reasons why you might think that a cesarean delivery and outcomes may not be as beneficial, like fetal presentation, which we touched on briefly before, as well as birth weight, they found that held true regardless. So survival was better with cesarean delivery, regardless of presentation, regardless of birth weight. However, in this study, they were unable to determine provider or patient intent regarding postnatal resuscitation, again, getting at that potential for confounding by indication. And what was also important to point out in this study is that they did evaluate maternal morbidity with cesarean delivery, including things like hemorrhage, including infection, including other potential maternal complications, which are important to consider when you're balancing the trade-off between fetal benefit and maternal risk. And in the pictures on the right, you can see what I was talking about before with the difference between a low transverse or horizontal incision on the lower uterine segment. This is typically done at later gestational ages and is associated with less morbidity in the current pregnancy as well as future pregnancies, versus that classical cesarean, which is a vertical incision, goes through the contractile portion of the uterus, is associated with more bleeding in the current pregnancy, requires future C-sections in all future pregnancies, and also is at an increased risk for uterine rupture in future pregnancies. So we've got another study, and this one really zeroes in on that maternal morbidity question. So this was a retrospective cohort study of 678 women with a periviable birth at 23 to 25 weeks, uses the data from the Consortium on Safe Labor, which we saw from that first study, to see what the association was between mode of delivery and maternal morbidity. What they found was the vast majority, about 82% at this time in the early 2000s, attempted a vaginal delivery, and 74% had successful vaginal deliveries. What they found was there was a lower rate of endometritis with attempted vaginal delivery compared to a C-section, and also with successful vaginal delivery compared to an unsuccessful vaginal delivery or a C-section. They found a lower rate of thrombosis with successful vaginal delivery compared to unsuccessful or a C-section. They found shorter hospital stay with vaginal deliveries. However, they weren't able to assess long-term risks in subsequent pregnancies. So definitely appears to be some short-term benefit of a vaginal delivery for the mother. But, potentially there is also some long-term benefit that is not measured in this study. And so where does that leave us? Again, in 2017, ACOG and SMFM did not recommend performing a cesarean delivery for fetal indication, which included both abnormal fetal testing as well as malpresentation. But again, I think as the fetal benefit increases, particularly as the evidence has shown at earlier gestational ages, including 22 weeks, I think there is some potential that this recommendation here may need to be revisited as that balance between fetal benefit and maternal risk changes over time. At 23 and 24 weeks, a C-section is to be considered and then recommended at 25 weeks. And then finally, our last intervention, delayed umbilical cord clamping. So we know that placental transfusion for 30 to 180 seconds after preterm delivery at slightly later gestational ages, 24 to 36 weeks, reduces the risk of death before discharge, as well as intraventricular hemorrhage. And that's from a Cochrane review. When we think about kind of the earlier gestational ages, there's not extensive data. The best data is from an RCT of preterm infants born from 23 to 31 weeks, and it was done in 2017 to 2018, looking at rates of death or IVH between delayed cord clamping versus intact cord milking. And what they found with this study was that there was actually a higher rate of severe IVH with intact cord milking in the 23 to 27 week strata, as well as for those babies delivered by vaginal delivery. And there was a higher rate of death or severe intraventricular hemorrhage with the umbilical cord milking in the vaginal delivery strata. And so definitely it appears based on this study that delayed cord clamping would be safer to perform rather than intact cord milking. I know there's also some practices of cut cord milking. I think it centers in Japan, and would love to hear from you guys during the Q&A session, because it sounds like you have some great outcomes and do cord milking differently than was done in a study with a lot of success. So where does that leave us? Here I have kind of summarized at least the ACOG and SMFM recommendations in the US of when we would consider or recommend each of these interventions at different gestational ages, with the most updated recommendation being that of antenatal corticosteroids that was published in 2021, and potential for some need for updated recommendations as these others were last updated in 2017. So in summary, these guidelines for OB interventions surrounding peri-viability just are going to have to evolve with increasing neonatal survival and improved outcomes after birth at these early gestational ages, because as they do, then that risk-benefit ratio between the neonate and the mother, it changes. And so do our guidelines. We need high quality research. I pointed out a lot that this is an area where there is not a lot of studies done. And so we have to understand what interventions are actually going to be beneficial to improve neonatal outcomes at these early gestational ages. And then finally, these decisions surrounding the OB interventions, we definitely are thinking and talking a lot about the neonatal benefits, but we can't forget about short-term as well as long-term maternal risks. And I look forward to some great discussion during the Q&A. Thank you.
Great. Thank you both for those very helpful talks. It's always nice for me as a neo to hear from the OB perspective how you guys think about things. So with those completed, I will turn it over to Dr. Battarbee to kick off our Q&A session.
Thank you, Kelly, and thank you, Ashley, for excellent talks. And it was great to receive many questions ahead of the webinar, and I think your two talks addressed many of the questions surrounding mode of delivery, steroids, and we can have a really good discussion about that. So one of the benefits of these webinars is the amount of time we have for a real discussion. So I would really encourage you to put your questions in the Q&A, and we can help answer some of them as we go along. So just to pick up some of the questions that we're going through during your talk, Kelly. So you presented the benefits of antenatal steroids, and the pendulum clearly is quite clear for the very extremely preterm babies, where clearly survival is really impacted and improved with steroids. But I guess the question is, what are the potential side effects or risks and harms from antenatal steroids was one of the questions in the chat. And I think there's been a lot of chat, certainly in the UK, about the timing of the steroids. And clearly the best thing is to be able to predict exactly which of those 22 weekers with that crystal ball will definitely deliver within your 2 to 3 days, and hopefully within the week of giving the steroids, because we know that that's where the benefits are most. And we know that there is potential long-term neurodevelopmental harm because of the HPA axis and how steroids work on the brain. So I guess my question to you is, how do you make that decision? How good are we at predicting the timing of delivery and hence influencing when we give our steroids? I don't think we are that great in the UK. I think my obstetric colleagues tell me they also struggle, and we also had the quantitative fibronectin come off not being available in the UK. So we have this app we use, but I don't know what happens in the US. So it would be great to hear your thoughts.
I think we're probably somewhat similar to your colleagues in the UK. I think we get it right probably somewhere around half the time. And I like that you said your crystal ball, because I was telling my patients that my crystal ball is cloudy today, so I'm not entirely sure. We know that it works well when we give it in that time frame. And so if we feel that a patient is at high risk for delivery in the next week, we want to administer it. But we also have to be cognizant that if we are wrong, the risk from giving it and then not having that kind of inner armamentarium to give later on if a patient stays pregnant but then comes in at a later preterm gestational age, that's really what we have to think about. And I wish I had a better answer, that we were so good at predicting who was actually going to deliver, but the fact is that we're not. And things like the fetal fibronectin have they gained a lot of popularity, thought that they were maybe the answer, and in some cases they helped, but they certainly didn't give us all the answers. So I think in obstetrics, we're still searching for how to easily determine if someone is going to deliver within the next week.
Yeah, and I guess the importance is counselling, isn't it? Telling these parents that actually we do know that a large proportion do not go on to deliver, and there is this chance that there are long-term harms from steroids. So my second question, I think, just carries on a bit. So as a neonatologist, I sometimes struggle with this. So I see it, and so I'm just bringing some of the comments in the chat together. I think if we are going for a survival-focused approach, and we have a very much a care bundle approach in the UK, it's perinatal optimization. So you give the steroids, the Mag-Sulf, all of it. So, because if you're going to go for survival-focused care, surely we should do it everything right from the beginning of the perinatal pathway with the obstetricians. So my question here is about the fetal monitoring. Now, my colleagues tell me they don't monitor it, the baby, because they don't know how to interpret it. So it's mainly intermittent auscultation versus continuous CTG. But I know that there are different thoughts. So what are your thoughts? And I can see lots of chat about monitoring of these during labor. What do you do, and what are your views?
It's a great question, and something that I don't think there's great evidence or even really clear guidelines from any of the, ACOG or SMFM. In general, I think most of our practices are, we would initiate monitoring when we're ready to do something about it. So when we are ready to intervene, just like you wouldn't order a lab test if you're not going to act on the results of, any test in medicine. And so that obviously, again, as we've been talking, varies by a number of different factors, but I think most people will initiate their monitoring when they're ready to act on it. That monitoring can take different forms: intermittent auscultation or continuous fetal monitoring. It also is going to vary depending on the clinical scenario. So monitoring in labor is at these early gestational ages can be continuous, or, if it's difficult to do, it could also be intermittent. And I think that's a conversation to have for patients that are at risk of a preterm delivery, but not actively in labor. We may actually plan to do intermittent monitoring once or twice a day, depending on the obstetric scenario that's going on. And then, yes, you're correct. The monitoring itself can be a little bit more difficult to interpret at early gestational ages because the fetal heart rate patterns change over time as the fetus develops. And so some of the typical patterns and expectations that we would have for a fetus at 34 weeks, we may not see at 22 or 23 weeks. And that's not necessarily an indication that there's anything wrong. It's just a less well-developed fetus. So I don't know that that answers anyone's question, but I think definitely from a neonatologist perspective, if you're wondering, like, why is the obstetrician not even looking, it may be because we feel like we don't have anything to offer at that point in pregnancy.
But I mean, coming on to some of the comments about the the guidelines from the ACOG and SFM about cesarean sections, for example, and strongly recommending something when there isn't much evidence. What are your views on that? Because surely it should be a discussion with the woman in front of you or the family to what they
Yeah,
want.
I agree. And I don't think it is as black and white as sometimes guidelines appear on a piece of paper. And then I think also, I highlighted many new studies after the 2017 guidelines came out. I think honestly, it's just time for some of those guidelines to be updated.
Yeah, I think an honest discussion that actually no evidence is probably a better place to have no recommendations and accept that more research and more studies need to be conducted. On that note, I'm going to hand over to Com.
Yeah, great presentations. Well done, really interesting topics. And one of the things that stood out to me is the discordance that we see between obstetricians and neonatologists in the slides Dr. Gibson was sharing. What do you think that we can do as neonatologists and obstetricians to reduce discordance in the care that we're providing? And where do you think that discordance comes from? What do you think's the kind of root cause of that discordance?
Well, I'll take the first part of that. I think the key to any time where you have discordance is just communication and talking. So at my institution, we actually wrote our institutional guidelines together with representatives from both obstetrics, MFM, and our NICU team. And I think having conferences like this, where, as an MFM, I'm coming and talking to many neonatologists so we kind of see each other's perspective. I think that's the way to limit some of that discordance. And I think it's more than just guidelines. We don't always meet this goal, but we try to do some of this counseling when a patient comes in at one of these periviable gestational ages as a group. So I'll actually meet with my neonatologist outside, kind of go over what is going on with this patient, why I'm concerned that they may be delivering soon. And then we'll go in together to talk to the patient so that we're all on the same page. We bring in their nurse, make sure their family's there. Not every situation is amenable to that, but that's our goal. And that kind of shared decision-making model, I think, can limit some of the discordance that we may see.
Just to piggyback on that, one question that I had, we know it's really important when caring for these patients to have folks involved who are optimistic that these patients can do well. Mm-hmm. What is the best way? We certainly on the NICU side of things see if these patients have a pretty relatively smooth NICU course and do well. What is the best way to keep our OB colleagues in the loop with how these patients are doing and the outcomes that we're seeing?
I can take that. So again, just modeling from my institution, we actually share our data. So our NICU kind of annually will say, we had, 15 to 20, 22 weekers last year, and these were their outcomes. And we actually share that data with our patients as well, so that they see both national data as well as our institutional data for where they're delivering. And I think that communication, we also have a conference where, and not just periviable, but just any complex patients we delivered and went up to the NICU. So we all kind of hear what that outcome is. Because you're right, sometimes we deliver them and then they go off to the NICU and, 180 days later they get discharged and we are not there to see that entire course. So sharing that information back with the obstetricians, I think, is the way to close that loop.
Thank you. I also wanted to give Dr. Battarbee a chance to talk about these on-call deliveries. I think I certainly myself am curious about them, and there also were plenty of questions submitted about what they look like, what the benefits are, and things like that.
Yeah, I'm happy to try and tackle that. I saw a few questions come through about classical cesarean deliveries and how do you choose and the, what's the difference. So I'll start with that first. When we are assessing at the time of C-section whether or not a low transverse or more horizontal incision can be made in the lower part of the uterus versus a classical or vertical incision on the uterus, a lot of it is just based on uterine size and development. And so at these early gestational ages, particularly at less than 28 weeks, that lower portion of the uterus just hasn't grown and developed, and there's not enough space between the uterine arteries on each side of the uterus in order to safely perform a large enough horizontal incision and deliver the fetus. And so we are forced to make a vertical incision, which goes through the contractile portion of the uterus and has those added risks. On-call deliveries is honestly something that we don't do routinely here at UAB. I think, or we don't intentionally try to do an on-call delivery. I guess maybe it's not one of our goals of delivery. I think from what I've heard, it has been used in some of the Japanese centers, and I think maybe one of the centers in Sweden, as well as potentially Iowa. But if you think about the on-call delivery is essentially delivering the fetus still within the amniotic membrane. So wouldn't obviously be an option for someone with preterm pre-labor rupture of membranes, but could be considered in those other scenarios. And I think the thought behind it, and I don't know if anyone from those centers wants to weigh in on any more specifics, is, that bag of water does provide some cushion and may prevent against any sort of trauma, or at least mitigate some of the trauma during both a vaginal delivery as well as a C-section. And so, could that reduce things like bruising? Could that reduce risk of head entrapment? Absolutely. And so I think something to continue to talk about and consider as we think about how best to care for these patients with periviable deliveries.
So there's a real mixed bag of studies on mode of delivery at these lowest gestational ages. And some of them may be divided between what was the intended mode of delivery versus the actual mode of delivery. And so in some of these studies, when they've looked at the intended mode of delivery, there wasn't such a clear difference between outcomes as opposed to studies that more focus on the actual mode of delivery. So there has been attempts in the past to randomized controlled trials, for example, at mode of delivery in preterm babies. What's your take on equipoise for future randomized controlled trials of obstetric interventions, for example, mode delivery or other periviable interventions?
As a researcher, I would love, and as a clinician, I would love to have some, randomized data to really help solve some of these questions. And I think if we're going to do the studies, they really need to be done ASAP, or it's going to be harder to do it as time goes on and more of these interventions become standard of care, or at least common practice, and then it may be more challenging to perform a randomization. I think I think that may be the only way that we know 100% that it is the mode of delivery that is resulting in higher or lower rates of morbidity versus, unfortunately, a lot of confounding that goes into the decision about whether or not to do a major surgery to deliver the fetus versus attempting to do a vaginal delivery. I think the existing studies, and I agree with you completely, really are varied. But I think at the very least, a lot of them do show this potential for confounding by indication, which is just really hard with statistical methods outside of an RCT to be able to completely account for, to make sure that the effect you're seeing is really from the mode of delivery and not something else.
Thanks. Can I pick up a question in the chat about something like Kelly mentioned? I think it was about the indications for delivery, and the earlier gestations, it's more PPROM, choreo. And so one of the questions in the chat was your thoughts about tocolysis to give time for those steroids. What are your thoughts, given sometimes indication is a PROM rather than maternal indications of the later gestations where it's more hypertension, etc.?
Yeah, I think tocolysis could be a talk unto itself. But certainly there does seem to be some benefit to a slight delay in a delivery if someone is truly in preterm labor and going on to deliver, which, as we already said, can be hard to sometimes sort out. If I have someone who is acutely infected, let's say they're febrile, they have leukocytosis and are very tender, that's probably not someone I would delay delivery because of risk for both maternal and fetal risk. But if someone's just laboring and maybe there's an infectious etiology as part of that, I do think it may be worthwhile to try a tocolytic and see if that gains you a little bit of time to potentially administer steroids or magnesium or transfer a patient to a higher level facility where they have the resources to take care of that neonate.
Yes, on that note, there were lots of questions about that exact problem of kind of regionalization of care and trying to transport before delivery happens. We certainly on the NICU end get phone calls every now and then of a baby who delivered precipitously at a level 1 or 2 nursery, but I'm sure you guys have a lot more before delivery phone calls. What does that look like in terms of how you're counseling these referral institutions and how you're deciding kind of over the phone what patients are safe to transfer versus get the NICU transport team there?
Mm-hmm. Well, I think you always start with just the history of the patient, and for me, I want to know if she's dilated. If they're very dilated, that's often a reason I'll say not to transfer because I don't want to have a delivery en route. That's kind of the least optimal outcome. And then you want to know other things just going on with the patient. Is she bleeding? Is she hemorrhaging? Things that would make her unstable to transport. But if she is simply contracting, not in active labor, then you also want to factor in the time to get here. For me, I live in Ohio, most transports are going to be about an hour. Out west, there are some transports that go several hours to move patients. And so looking at all of those factors together, I think you have to talk with whatever the site is that's calling you, as well as your resources, and decide, can we do a maternal transport or should we potentially plan for neonatal if we think delivery is going to happen before they could safely get here? So I don't have a perfect answer, but I do think having those channels in place so you know who to call helps.
And in some parts of the world, they've achieved up to 95% transfer prenatally to the perinatal care centers. Some centers will even send the neonatal transport team to accompany the mother. So there are centers and regions around the world that are doing some interesting things to improve that peri-viable transfer and prenatal transfer to a center of excellence. How do you all feel about the timing of antenatal steroids in that situation where you're talking about a prenatal transfer? And what would you recommend for a level 1, level 2 center who has a peri-viable infant with threatened preterm labor?
Usually if they're transferring and we think delivery is imminent, then I usually have them administer it before transfer. I don't know. How do you handle that?
Yeah, I would say we get, in Alabama, we get transfers from all over the state, and even centers that are, not equipped, or not as equipped to handle, a 22-week delivery. They are all very able and a lot of times have already administered steroids before they even call us. And so I think, particularly for those babies, like Dr. Gibson had mentioned, that you think are going to deliver somewhat shortly after arrival, going ahead and giving steroids or starting magnesium or antibiotics if appropriate, can definitely be beneficial and are generally, there isn't a lot of concern or pushback on the side of the transferring provider because they do that at later gestational ages as well. So typically not difficult to get those administered before transfer.
And a follow-up question that was in the chat related to this was about administering tocolytics. It could be related to the use of steroids and trying to delay long enough to get steroids or transport.
Yeah, I think, and Dr. Gibson touched on it a little bit as well. I think tocolytics can be beneficial in the short term when trying to administer steroids or safely transfer to another hospital.
Yeah, touching on your point, Colm, we struggle in the UK to even get our 23-weekers and 24-weekers delivered in the right place. We've certainly improved, and our national audit data show that, but it's often really hard to find a bed for mom and baby. And we've tried all sorts, including a single point of call that you phone or an app. But because things change so often, nothing is up to date. We still got this process of phoning around hospitals. I don't know if the US has got the system sorted, but I think this organization of the perinatal pathway is quite fragmented in many countries. So be useful to hear what it's like in the States. Are you any better?
As far as I know, it varies a lot by state and region in the US. I think in Alabama we have a long-standing regionalization where all the babies end up in Birmingham, or in Mobile or Huntsville. They're the kind of three big perinatal centers if there's a major problem. But it took a long time to set those networks up, maybe 20 years ago. But I know that in different states, there's not necessarily the same level of regionalization. I don't know if Kelly, if you have a different experience in Ohio.
No, I'd agree with that. I think it varies on the state, and also on kind of how rural the state is. I know I attended a talk for what they had set up for Alaska, which is very rural, and they had it actually quite fine-tuned. Whereas then I come back to Ohio, and we have more hospitals available, so I think there's less of an acute need, and so we are probably not as good as some of our colleagues who have to deal with patients who are in a much more rural setting.
And I guess it does depend on how your health services are funded, and it's the whole pathway needs to work together, including, I think some of you talked on the transport, the ambulances, or the parents who present at centers. They may or may not know whether the center they presented at is a optimistic 22-weeker center or not. And I guess some of the talks, even from the previous webinar about counseling, is that we should really be quite transparent to parents about this population of infants and our experience.
Yeah, absolutely. I agree with that completely. I think we talk a lot about, on the NICU end especially, about learning from our colleagues at kind of centers outside of the US. I think a lot have very good outcomes for these tiniest patients and have been doing it a lot longer than we have here in the States. So I'm curious if there's kind of the MFM side of that, where you also have any sort of built-in networks to collaborate with international colleagues to hear from the OB side, kind of how they're approaching things and how they're improving their outcomes.
I would just say, from being on the steering committee of the Tiny Baby Committee, it's been incredible the work that's been done to try and generate this network of, international experts, those with expertise, in this area, in order to both collect data as well as share practices to try and figure out what's the best. I am not aware of anything in MFM that's that organized, but I think the Tiny Baby Committee provides a great model of how this could be replicated for other topic areas, for other specialties that really could improve care globally. I think things that SMFM has done here recently is just had a global congress this past fall, trying to engage international colleagues, I think, a little bit more intentionally. And I know that is of interest and something they plan to continue in the future. But even these kind of more focused committees solely looking at a particular content area, I think is a great opportunity to create more of these.
Yeah, like you mentioned, the Japan style of delayed cord clamping, where they kind of cut an entire cord segment and send it to the NICU team, I think would be great to hear from their obstetricians how they approach that. Definitely down the road, more ideas for the future.
Yeah, no, I absolutely agree. I think these numbers are small per country. They're still small. And I think the only way to improve outcomes for this population is to work together internationally. So the Tiny Baby Collaborative, we're also starting up a new group in the UK, is the only way forwards. And I think because the perceptions are so different, and sometimes we are guilty as well as pediatricians, we have polarized views, we bring our own values, and we may have optimistic or pessimistic views of this population. And actually, we need to keep up to date with the data and the survival figures so that we accurately present it to the parents. And we can't do that unless we all talk to each other. So I've really enjoyed this webinar, and I've been really honored to be part of this panel. So thank you very much for having me.
Yeah, you touched on it really nicely during the talks about the difference in denominators. And I know, Ashley, we have some data at UAB that we can present to our families about survival statistics at different time points from the maternal perspective, from admission through antepartum admission, through labor, through delivery room, and through to NICU discharge, with kind of how those denominators change. What do you think that was helpful, or do you actually use that in practice when you're counseling the parents?
Yeah, I think it's extremely helpful. What Dr. Travers is referring to, we actually have little like laminated cards that we're able to, carry along with our hospital badges that have our own institutional data that provides survival kind of at each of those step points. So survival among, patients who come in and are going to deliver, survival among those that are admitted to the NICU, and that obviously you lose some babies that may pass away intrapartum or in the delivery room, and so it is really helpful, and even from kind of a educational tool for patients to understand that things do change over time, and as the hours and days go by following a periviable delivery, the individual situation may change too. So it's extremely helpful. We all really like having them on our badge. We can provide the data that's specific to our institution, which I think is more helpful than sometimes like national data, because parents may not be interested in what happens nationally. They want to know what happens, to their baby at the center they're delivering.
Yeah, certainly in the UK, we follow the BAPM framework, and in that we've got recent national figures which we published in the BMJ Medicine, but on top of that, we have a risk stratified approach. So depending on the mother in front of you, clearly there are certain risk factors that will increase their risk of adverse events. So I think presenting local figures is really important, but the problem with that is the numbers are very small, and so maybe presenting both local and national. And being honest that, we are still learning.
We have a few minutes left. There's a lot of questions that were submitted about kind of more logistical things. I think one that I liked was about thermoregulation in the DR for these patients. We certainly know that turning the temperature up is really important. Have you found other ways that we're able to ideally provide delayed cord clamping while also keeping the patient warm, whether it's some sort of sterile wrapping when baby's at the perineum, or other approaches that have worked well? I think this is always a work in progress for a lot of us.
I'm aware of there was a randomized control trial last year at PAS. I don't think it's published yet. Forgive me if it's already published, where they were doing a plastic polyethylene bag during delayed cord clamping, but it didn't improve thermoregulation. But I know that's in a center that has a good 80-degree Fahrenheit delivery room and operating room. So there isn't a lot of data on improving thermoregulation during delayed cord clamping, and whether it improves outcomes, I think, is an open question.
Any other burning last minute thoughts? I think that was a wonderful presentation and gave a lot of us on the NICU end a very helpful insight into what goes through our OB colleagues' heads and how we're helping to manage these maternal fetal diets.
The other thing, kind of circling back around to the communication, I think it's quite appropriate to always just ask the question to kind of understand what the OB provider or MFM provider is thinking when they are or are not doing something. Again, kind of back to what Dr. Gibson mentioned about kind of the pre-huddle of talking to, each other to figure out exactly what the clinical scenario is, what you think the options may be for resuscitation after birth, what are the, maybe surgical risks if the question is, whether or not to do a cesarean or not, and just having that kind of open discussion, asking each other, the questions that you're wondering about, rather than assuming that, someone is or isn't doing something for a particular reason. And sometimes, it can be helpful if we are, as obstetricians, underestimating how we think, the baby may do after birth. Or, if you guys don't realize the surgical risks of a C-section in a particular patient because of, whatever it is, obesity, prior surgeries, a bleeding disorder, whatever it is, I think having that conversation can be really helpful on both sides.
Yes, absolutely. I think we're both just at the end of the day advocating for our patient what we think is best, but certainly I am not an MFM expert. So hearing from those who are, what's going through your head and how you're approaching a certain patient is very, very helpful.
Yeah, and I agree. And I think it's really important to be very clear in our documentation of, are we all aiming for survival focused care? If we are, then I think we have to give, every chance possible. And that is optimizing everything we can possibly do. But I think we all need to be on the same page. And if we're not, that needs to be clear as well. And then that can only happen with communication. So yeah, so these webinars are extremely important for us to come together and really give hope to this population of babies, because if we don't, then what's the point? We're doing this because we believe that it is possible for them to survive and that it is possible for us to improve their care. And we can only do that if we work together. So.
Very well said. I think our time is up for today, but thank you so much, Ashley and Kelly, for speaking, and Cheryl and Colm for joining me in moderating. And I'll hopefully catch you guys again in a few months for our next webinar.
Right. Thank you.
Thank you, everyone.
Thank you.